Welcome everyone to today's culminating webinar presented by Brennan, Mana, and Diamond as a final recap on hot topics surrounding the ending of the public health emergency, which happens tomorrow on May 11th, 2023. My name is Amanda Waesch, and I'll be moderating today's webinar, and I'm delighted to introduce my partners who will be participating in today's recap. And what would a presentation be with attorneys without a disclaimer? So even though we are attorneys, we're not your attorneys. And so this information should be used for informational purposes only and not construed as legal advice. To kick us off, I'd like to introduce my partner, Ashley Watson. Ashley is a partner in our Columbus office, and she's going to provide us with a recap on the ever-changing telehealth rules after the PHE. After Ashley, we will kick it over to Daphne Kackloudis, who is a member and is also located in our Columbus office. Daphne will recap the ending of the PHE's impact on Medicaid, as well as good faith estimates under the No Surprises Act. Jeana Singleton is a member in our Akron, Ohio office, who will provide us with a synopsis of changes concerning state licensure requirements and various waivers that will end with the PHE's end. I will provide a brief overview of the billing and coverage rules related to COVID-19 testing, treatment, and vaccines with the ending of the PHE. And finally, we will conclude with Bryan Meek, a partner in our Akron office, who will review any employment concerns with the ending of the PHE. Bryan is also the host of Employment Law After Hours, a YouTube podcast focused on hot topics in the employment arena. And if you are not a subscriber, please be sure to check it out. Throughout the presentations, all participants will be muted. Please feel free to type your questions in the questions box of your control panel, and we will be sure to answer them throughout the presentation or at the end during the Q&A session. With that, I will turn it over to Ashley Watson to kick it off.
Thank you so much, Amanda. So we are going to do a whirlwind summary of telehealth after the PHE. For any of these topics, if you're interested in a deeper dive, we've all done much longer webinars, full hours, that I think are recorded, so you can reach out to us if you need copies of those. Next slide, please. So we're going to start talking about flexibilities for telehealth that have been extended beyond May 11th, the official end of the PHE, for Medicare beneficiaries to start. These flexibilities that I'm going to talk about for the next couple of slides will last until December 31st, 2024. Specifically, some flexibilities that we want to call out are there will be extended reimbursement for some audio-only telehealth services, which is great if you serve a population that does not do great with electronic technology. There's an expanded definition of originating and geographic sites that will include anywhere the patient is located, including the patient's home. Also a great improvement and hopefully something that will remain permanent. Also, we are allowing the use of telehealth to satisfy the face-to-face encounter requirements for recertification for hospice care. So if you're a hospice care provider, through December 31st of 2024, you'll be able to use telehealth to satisfy that requirement for Medicare. Also, Medicare is doing a study on telehealth through the Medicare program integrity model. This is great and is a good sign because it means that hopefully positive results will result in permanent changes to telehealth and make sure that we can continue providing those services to all of our patients. Also, through December 31st, 2024, Medicare is extending the safe harbor exceptions under the health savings account eligible high deductible health plans for telehealth services. And also the acute hospital care at home program is going to continue to provide hospital services to patients in their homes using telehealth. These programs provide similar services as those administered during inpatient visits, like physician visits and monitoring, drug prescription, nursing services, diagnostics, etc. There's a lot of advocacy around making this program permanent because it's been very helpful during the PHE, but right now it is set to expire on December 31st, 2024. Next slide, please. Some more key changes that will remain around through December 31st, 2024 include FQHCs, federally qualified health centers, and rural health centers can provide telehealth services to Medicare beneficiaries instead of being limited to an originating site provider for telehealth. So for non-behavioral health services, FQHCs and RHCs can be a distant site provider rather than being limited to the beneficiary's location. Note that we said non-behavioral health services because we do have another update for behavioral health services specifically. Medicare patients can receive telehealth services authorized in the 2023 Medicare physician fee schedule in their home, which is great, through December 31st, 2024 at least. And there will be no geographic restrictions for originating site for non-behavioral or mental telehealth services. Again, the distinction between non-behavioral health and behavioral health, and we'll talk about behavioral health in a second. Also, the in-person visit within 6 months of an initial behavioral or mental telehealth service is not required. That is going to correspond to a rule in 2020 that Congress imposed for telemental health coverage under Medicare, and that created an in-person exam requirement alongside coverage of telemental health services when the patient is located at home. Under the rule, Medicare was going to require a visit in person within 6 months of the initial telehealth service. So that in-person exam requirement is going to be not required at least through December 31st of 2024, and we will keep an eye on that to see if that is permanently extended or if CMS is going to implement that after December 31st, 2024. Also, telehealth services can be provided by a physical therapist, occupational therapist, speech-language pathologist, or audiologist and reimbursed by Medicare at least through the end of 2024. A couple of notes also on temporary flexibilities that will end at the end of this year, 2023. During the public health emergency, CMS instituted higher reimbursements for telehealth services at non-facilities, like at a patient's home. Reimbursement parity for services performed via telehealth that typically would have been performed in person will end at the end of this year. There are a lot of states that have established payment parity laws for telemental health and telehealth. However, you may or may not be in one of those states, so definitely pay attention to your state laws and also to CMS to see if the telehealth and non-telehealth parity for payment continues on after the end of 2023. Additionally, CMS temporarily changed the direct supervision rules to allow the supervising professional to be remote and use real-time interactive audio-video technology. This is for things like incident to billing under Medicare. This change was temporary because CMS was concerned widespread direct supervision through virtual presence may not be safe for some clinical situations, like surgeries or something, for example. CMS rejected requests to make virtual direct supervision a permanent feature in Medicare. Therefore, virtual direct supervision will expire at the end of 2023, the end of this year. Next slide, please. While we are left with some uncertainty, of course, as to whether the flexibilities that I just talked about will be ever made permanent, although hopefully they are, there are some permanent changes to Medicare and telehealth that were specifically in response to COVID. So FQHCs and RHCs can now serve as distance site providers for behavioral and mental telehealth services. So remember, we just talked about December 31st, 2024 being the end of flexibilities for FQHCs and RHCs that are providing non-behavioral and mental health services. Now we're talking about permanent changes that allow FQHCs and RHCs to serve as distance site providers for behavioral and mental telehealth services. Also, Medicare beneficiaries can receive telehealth services for behavioral and mental health care in their home permanently. Additionally, for behavioral and mental telehealth services, there are no geographic restrictions for the originating site, and also they can be delivered using audio-only communication platforms. So really, Medicare was seeing that there was a lot of benefit to providing mental health services through telehealth platforms during COVID, so they have extended a lot of those flexibilities permanently. Next slide, please. This is a big, important announcement for DEA teleprescribing controlled substances. Of course, departments other than CMS have also recently announced changes in telehealth policy. Telemental health, telepsychiatry, and teleprescribing became, of course, crucial practices during the pandemic and big business. Many providers are concerned that DEA flexibilities for teleprescribing will not be extended due to overreach of some national telehealth companies that were found to be improperly prescribing drugs for mental health conditions. So for the duration of the PHE, the DEA waived the in-person exam requirement for prescribing controlled substances. This allowed established and new patients to receive medically necessary prescriptions of controlled medications through telemedicine. The DEA proposed much-awaited new rules for the permanent telemedicine flexibilities back in February. There was a public comment period that ended at the end of March and resulted in over 38,000 comments. Many of the flexibilities in the proposed rule were similar to those adopted during the PHE, but with additional safeguards that reflect a crackdown on some of the telehealth businesses that were prescribing without following appropriate protocols. Because of the just abnormally huge response to the proposed rules, the DEA announced just yesterday that they are extending flexibilities through November 11th, 2023. And for any patient who established a patient-provider relationship during COVID through telehealth, there will be a grace period for seeing that patient in person for another year through November 11th, 2024. And as a reminder, the COVID flexibilities allow teleprescribing of controlled substances if the prescription is issued for a legitimate medical purpose by a practitioner acting in the usual course of business. The prescription must be issued pursuant to an appropriate interactive telecommunications system. The practitioner must be authorized under the DEA, of course, to prescribe that class of controlled medication, and the prescription must be consistent with all the other requirements of federal controlled substances laws. A couple of other details on the slide that I won't go through talk about what the proposed rules were proposing. But now that we have another 6 months to kind of get prepared and figure out what the DEA is going to do, we will keep you updated if anything new comes out, but for now, you can still rely on those COVID flexibilities for teleprescribing controlled substances, at least through November 11th, 2023, and then with that grace period through November 11th of 2024. Next slide, please. Just a quick note on Ohio's telehealth laws. Please note that many telehealth regulations can be found in your state laws, so if you're not in Ohio or not an Ohio provider, please reach out to us if you have any questions and we can help you identify which laws apply to you. In Ohio, we've passed new telehealth provisions within the last year to ensure that telehealth practices are protected and also appropriately regulated. So generally, these rules only govern providers who are serving patients located in Ohio. Remember, if you're providing telehealth, you need to pay attention to where your patient is located because most of the laws will apply there. Providers must meet applicable standards of care. Essentially, the same standard that you have for an in-person visit also applies to telehealth visits. All elements of a bona fide healthcare visit standard of care must be met in order to use any sort of telehealth, especially audio-only services. And additionally, rules set forth requirements for physicians and physician assistants and also APRNs to prescribe, personally furnish, or otherwise provide non-controlled prescriptions and controlled prescriptions through telehealth. One note about controlled prescriptions. Ohio's law requires a physician exam to be done prior to prescribing a Schedule II drug to new patients unless there's several exceptions that can be met for telehealth and teleprescribing. Next slide, please. Ohio Medicaid has also published its own rules specific to telehealth. Again, please check your state laws if you're not an Ohio provider. In Ohio, providers have a responsibility to deliver telehealth services in accordance with HIPAA and maintain documentation as required. Additionally, for practitioners who render services to individuals through telehealth for a period longer than 12 consecutive months, the telehealth practice or practitioner is required to conduct at least one in-person annual visit or refer the individual to a practitioner who can do that annual visit. So those are just some things to note in Ohio. This is a whirlwind, like I said, of all of the regulations. So if you would like more details, I'm happy to answer any questions, or you can consult the longer presentation that I did before. Amanda?
Awesome, great. Thank you so much, Ashley. It doesn't look like we have any questions right now, but don't forget, if you have any questions, go ahead and submit them in the Q&A or in the chat box, and we'll be sure to answer them throughout the presentation. We will now turn the presentation over to Daphne.
Thanks, Amanda. Great recap, Ashley. We are going to dive into Medicaid. So if you could go to the next slide, please, that would be great. I want to take you back in time to March 2020, when, in response to the PHE that had been declared on January 31st of that year, many state Medicaid programs, including the Ohio Department of Health, implemented operational changes to their Medicaid programs to promote enrollment and access to services. At the same time, Congress passed the Families First Coronavirus Response Act, the FFCRA, which you might remember, which did many things, including providing states with a 6.2% increased federal medical assistance percentage, or FMAP. In exchange for an enhanced FMAP, so more money, states were required to keep Medicaid enrollees in the program until the end of the month in which the PHE ends. And that change, importantly, eliminated the need for state Medicaid programs to reevaluate Medicaid enrollees' eligibility during the PHE and ensured that people retained coverage during the pandemic. Fast forward to December 2022, so just recently, about 2.5 years after the beginning of the PHE, when at that time, Congress passed the Consolidated Appropriations Act of 2023. That piece of federal legislation includes a number of provisions related to Medicaid, including the thing we're talking about today, which is delinking the Medicaid continuous coverage requirement from the public health emergency and beginning the unwinding after March 31st, 2023. The result of ending the continuous Medicaid coverage means that states are resuming routine eligibility operations. Ohio actually began its normal eligibility operations in February of 2023, and the Ohio Department of Medicaid is now requiring all members to begin the redetermination process, meaning that right now, all eligible members have to renew their Medicaid coverage. The result, of course, is that some Medicaid members will be disenrolled from Medicaid. And ODM began sending its first round of termination letters beginning on April 1st. So we're a little more than 1 month into that process. Just sort of for what it's worth, currently nationwide, there are about 91 million total enrolled Medicaid beneficiaries, and 15 million of those are expected to be terminated as a result of the continuous coverage provision of the FFCRA. And because we're going to begin to see an increase in the number of people who lose Medicaid coverage and become uninsured, we want to make sure that you and your organization have a good understanding of the No Surprises Act, which we'll recap later. Next slide, please. Okay, so first, the CAA set the continuous coverage end date, as I said, on March 31st of 2023 and directs states to begin routine operations. This means a lot of people will be terminated from their Medicaid program. Beginning on April 1st, states were permitted to resume disenrollment of people who are no longer eligible for Medicaid, but only after the state conducts a fresh and complete renewal, including examining eligibility for all categories of Medicaid. And states have 12 months to initiate the renewals and an additional 2 months to complete processing. So most states are already underway in conducting their redetermination process. Next slide, please. The redetermination process begins with an ex parte review, which means that the state will use quote unquote recent and reliable information at its disposal to determine eligibility before requesting information from the enrollee. The CAA, that federal law I mentioned, requires that states get updated contact information before they do the redetermination. And each state has to submit a verification plan to the federal government that essentially sets forth all the ways in which it's going to attempt to collect information by using a variety of data warehouses before it reaches out to enrollees themselves. And if the ex parte review is unsuccessful, so if the state can't use those processes to match up data, then the state must actually send a renewal form to the Medicaid beneficiary. The state must enable individuals to submit the information that the state's requesting in person, by mail, online, or by telephone. So as you can imagine, the states have to create this whole huge infrastructure to take in this information that they hadn't necessarily done before the PHE. The states are also required, as I said, to make a good faith effort to contact the individual about termination by multiple modes. So by calling them, by sending them a letter in the mail before they actually terminate them because they have a bad address or something like that. I think I mentioned this, but importantly, states are required to consider individuals for all categories of Medicaid eligibility and must seek to get that information regarding their eligibility in these other eligibility categories of Medicaid. So the state is really required by the CAA to do everything it can to keep the person on Medicaid or see if they're otherwise eligible for another category of Medicaid before they disenroll them. States are not allowed to send advance notice of termination to individuals who were found ineligible during the PHE, like if they moved and didn't update their address or something like that. They couldn't, before this redetermination period, just disenroll them. They have to do this full renewal prior to taking any adverse action. Next slide, please. In addition to ending continuous coverage, the CAA also gives states additional financial support during the unwinding period. So they have to do all this administrative work. So part of the CAA, in addition to ending continuous coverage, gives the state some additional money during this unwinding period. The CAA gradually is phasing out the enhanced FMAP through 2023, which I told you about. And this additional funding that they get as part of the CAA will support the states as they work through this huge number of eligibility reviews ahead of that date. To continue to receive that enhanced FMAP through 2023, the states are required to follow all these new federal eligibility requirements, maintain updated contact information, and like I said, generally try to keep people on Medicaid. Next slide, please. So this should be no surprise to you, but the unwinding of continuous coverage is going to create some problems for people. We anticipate that problems as a result of ending the continuous coverage include the failure to renew ex parte, which of course will result in people falling off the Medicaid rolls, just the sheer number of enrollees that the state has to redetermine is already overwhelming their systems. And then importantly for you, one of the results of unwinding is that many Medicaid enrollees will lose coverage and become uninsured. And that means that you have to pay attention to the No Surprises Act for a greater number of people. Next slide, please. The No Surprises Act is essentially a federal consumer protection law that does a bunch of things, including trying to curb the practice known as surprise billing. That is really encompassed in Part 1, the Part 1 regulation that implements the legislation. What we're thinking about today or paying particular attention to is Part 2. Part 2 is a series of federal regulations that requires healthcare providers and facilities to provide a good faith estimate of charges to uninsured or self-pay individuals. Next slide, please. Under Part 2, providers are required to give uninsured or self-pay individuals a good faith estimate of the cost of items and services. And when we say self-pay, we mean people who genuinely do not have insurance or are uninsured, or people who have insurance and choose not to use their insurance benefit for a particular item or service. And just one word of caution that the good faith estimate requirement in Part 2 has a much wider applicability than Part 1, which is really the surprise billing component. So even if you don't think that the surprise billing component applies to you, you should know that the good faith estimate requirement probably does apply to you. It applies to like literally every healthcare provider. Next slide, please. So the No Surprises Act requires providers and facilities to make a good faith estimate of the expected charge for items and services scheduled. Items or services includes all encounters, procedures, medical tests, supplies, prescription drugs, durable medical equipment, and fees, including facility fees, provided or assessed in connection with the provision of healthcare, including items or services such as those related to dental, vision, substance use disorder, and mental health. And that language is straight out of the federal regulation. A good faith estimate is a notification of an expected charge for a scheduled or requested item or service. In general, the good faith estimate should reflect the amount the provider or facility expects to charge for the items or services provided. It should include items or services reasonably expected to be provided in connection with the scheduled or requested items or services, and it should be provided in clear and understandable language. The good faith estimate should include the total expected charge for providing the scheduled item or service, expected ancillary items or services reasonably expected to be provided with the scheduled item or service, any items or service reasonably expected to be provided by another provider or facility, and the expected billing and diagnosis codes. Next slide, please. You can see here the information that the good faith estimate is required to include, including the patient's name and date of birth, a description of the primary items or service, an itemized list of items or services, as I already said, the diagnosis codes, expected service code, the name, NPI, TIN, and location of the provider, and a list of items or services that the provider anticipates might require separate billing. Next slide, please. For items or services scheduled, these are the timeframes within which you have to provide the good faith estimate based on when the item or service is scheduled. So for items or services scheduled at least 10 days in advance of the appointment, the good faith estimate must be provided within 3 days after scheduling. For items or services scheduled at least 3 days in advance of the appointment, the good faith estimate must be provided within 1 business day after scheduling. And anytime an individual requests a good faith estimate, you must provide it within 3 days following the request. So these are pretty tight time frames. Just something to be aware of, a provider or facility is allowed to issue a single good faith estimate for recurring primary items or services, but the scope of that good faith estimate for those recurring services cannot exceed 12 months. So if it does, you have to issue a new good faith estimate. And I think that's about it for me and the good faith estimate requirement and the unwinding of the PHE. Amanda?
Awesome, Daphne. Really great information, especially as it relates to the No Surprises Act, which we've been talking about since its passing and implementation. We did have one question for you, Daphne, and this relates to the Medicaid and the disenrollment process. How are you seeing providers informing key stakeholders of these updates and changes? And so I assume that this means providers notifying their patients, right, and the communities that they serve. And what is your recommendation to those providers?
So the state of Ohio, and probably other states as well, are required to submit a plan to notify stakeholders. So the state, in many instances, is working with the Medicaid managed care plans, community organizations, all kinds of entities that regularly interact with Medicaid beneficiaries to inform them that the continuous eligibility will be ending and that they will be redetermined. So I think if you are a provider and you have a Medicaid population, it is reasonable for you to inform your patients, maybe by putting a notice in your waiting room or maybe flagging your Medicaid beneficiaries and letting them know that redetermination will be happening. And if you're also talking about how to inform your patients about the good faith estimate requirement, there are all kinds of requirements for how you need to notify them that they may request a good faith estimate, that they're entitled to a good faith estimate, and we can provide that information to you afterward. If you want to reach out to us, I'd be happy to do that.
Awesome. Thank you so much, Daphne. Great information. Yeah, and if you want more information about the No Surprises Act and the good faith estimate, please feel free to reach out to Daphne for more information. And with that, we'll turn it over to our next speaker, Jeana Singleton.
Thank you, Amanda. So with the pandemic, the PHE starting in 2020, there were a number of flexibilities that the federal government and the states implemented to assist with helping patients to maintain health care and to continue receiving the services they needed. If we could go to the next slide, please. But now that the PHE is ending, we need to remember that a lot of those licensure flexibilities and waivers related to licensure are ending also. In particular, health professionals need to meet the state's licensure requirements for where the patient is located. However, due to the growing use of telehealth, many states are revisiting the licensure process and minimizing barriers to access to ensure continuity of care and preserve regulatory oversight. So the first key thing for our providers to remember is that you have to think about where your patients are located and where you'll be seeing the patient. If you're doing telehealth, for example, and the patient's located in another state, you must meet the licensure requirements of the state where the patient is actually sitting. Notably, the same standards for licensing apply to providers regardless if the care is provided in person or if they're providing delivering care virtually. And for example, in February, the Ohio Medical Board released its rules related to telehealth. To practice in a state, providers must meet specific requirements, including documentation of educational qualifications, satisfactory performance on qualifying examinations, and completion of background checks. In addition, they must normally maintain and renew their license, pay annual fees, complete continuing education, and complete other requirements specific to the licensing state. This is why obtaining licensure in multiple states was quite burdensome before the PHE, and states broadened their cross-state licensure oversight. On that note, many states have made an effort to expand their cross-state licensure, including telehealth services, for instance, by recognizing licenses in other states, allowing pre-existing provider-patient relationships to continue when the provider is in another state, and only requiring telehealth registration instead of a full license. However, every state is different. So please make sure you check the rules in the states that apply to your practice and where your patients will be sitting, because you certainly don't want to run afoul of any of the licensure requirements. And we'd be happy to help you with figuring out those requirements if you need assistance. Several states use telehealth registrations as a pathway for out-of-state providers to practice telehealth in their state. If a provider is in good standing, they can provide telehealth services in another state if they complete the state's telehealth registration requirements. Usually, the requirements under these arrangements require providers to have a current, valid, and unrestricted license in another state, require that they are not subject to any past disciplinary proceedings in any state where the provider holds a professional license. It generally requires that they must maintain and provide evidence of professional liability insurance. They must not open an office or offer in-person treatment in that state, and they must register annually and pay a fee to the appropriate state licensing board. Of course, every state will vary in what they require, but those are the trends that we're seeing. The other method more states are relying on is implementation and adoption of the multi-state licensure compact. And every profession has its own version of a compact. So what we're seeing is that states have to adopt each compact for each profession. It's not like there's one provider specific compact that applies to everybody. But if your state has adopted a multi-state licensure compact for any of their healthcare providers, this will allow the healthcare providers that it applies to practice in states where they are not licensed if they hold a valid license in good standing in their home state. So you still have to apply through the compact, but it makes it easier to move from state to state. So you need to know what the compact applies to for each professional licensure board. And a good example is that here in Ohio, there is a nurse licensure compact that applies to RN licenses, but not APRN licenses. So for example, a nurse practitioner would not have a compact license in Ohio, but they would also be a registered nurse by virtue of being a nurse practitioner. So their RN license would be part of the compact. However, it is still helpful for the APRNs in Ohio because APRN licensure is still expedited merely by the fact that the RN licensure falls under the compact and is required and is a requirement to obtain APRN license in Ohio. Next slide, please. So health professionals, oh, you know what? I went backwards. Never mind. Here we go. Some states use their emergency authority to waive certain aspects of their state licensing requirements throughout the PHE that would allow for easier moonlighting and out-of-state telehealth. Those cross-state waivers are ending with the end of the PHE, and many states have actually already ended those waivers. Regardless, you need to know what your state requires. One emerging trend that we're seeing is that state law among the different states is temporary practice laws. These are for when there is an established provider-patient relationship to ensure continuity of care across state lines. Most states have implemented these allow providers to practice for a limited time, for example, less than 30 days usually, in another state if the patient is temporarily in another state. But of course, that's all very state specific, so you have to understand if your state allows temporary practice or the state where the patient is going to be. Of course, a full license from a state grants the professional ability to practice legally in that state to the full scope of their license. However, as we all know, going through the full licensure process for our physicians, nurses, all of our healthcare providers, depending on the process, it can be quite burdensome and take a long time, quite frankly, to obtain a full license in multiple states. And that delay in time can mean a delay in patient care or the delay in revenue for the practice. To tackle these challenges, states are increasing steps to coordinate the licensing process to allow providers who practice in one state to provide telehealth in others. Some states allow providers from other states to provide telehealth services if their state has a common border with another state. That's one example. Other states are adding exceptions to preserve the continuity of care. For example, a state may allow a provider to continue to provide care for a patient in another state via telehealth if there is a pre-existing patient-provider relationship and the provider has performed an in-person exam within the previous 12 months. But those are just examples. Not all states are the same. And then finally, numerous states have passed legislation to permanently allow out-of-state providers to practice telehealth in their state if they follow the state's requirements. On that same note, some are allowing telehealth practice in their state by out-of-state providers if the providers are already licensed in another state, while others have a registration requirement simply for telehealth. And finally, other states require out-of-state telehealth license recipients to pass an exam in their state. So as you can see, the states are all over the place as to how they are handling the idea of cross-state practice, particularly due to telehealth. As I referenced before, many states have adopted multi-state licensure compacts. As a brief recap, licensing compacts are one way states can maintain their regulatory oversight of the care provider and provide a fast pathway to interstate practice. The compacts require that states agree upon a uniform standard of care and enact state laws to support that standard of care. Compacts decrease the time-consuming process for providers seeking to practice in multiple states, the time that it takes to obtain a license. The average wait time, for example, for a licensed physician trying to practice interstate in the medical licensure compact is 19 days, whereas it takes as long as 4 months for an individual state license if you go through the full licensure process. Multi-state licensing compacts will continue to increase in popularity as telehealth practices expand. So I think we'll just continue seeing these taking off, and many states have adopted them already. In Ohio, we have a number of multi-state licensure compacts, including occupational therapy, psychology, physicians and medical, audiology and speech pathology, physical therapy, nurses, not for the APRN license, but for the RN license, and a counseling compact. Next slide, please. And to wrap up licensure considerations, there are a slew of supervision waivers that CMS implemented for the PHE, which are coming to an end in 2023 when the PHE ends. Some of these will end May 11th when the PHE ends, and others will end at the end of this year, December 31st. For example, there's no more direct virtual supervision when direct supervision is required. However, what had happened is CMS rejected its temporary fix of allowing direct virtual supervision, where the supervising professional could be remote and use real-time interactive audio video technology to supervise. CMS is not keeping this as a permanent feature, unfortunately. Therefore, it will end at the end of the year, December 31st, 2023. CMS also had a waiver of the CRNA supervision requirements for anesthesia care provided by CRNAs if supervision is required by the state law. I would note that Ohio never changed this requirement. So our CRNAs have continued to meet the supervision requirements of Ohio's law because supervision is required just for a mere requirement of practice in Ohio. Another waiver that is coming to an end is that there will be respiratory care supervision requirements will go back into effect. For critical access hospitals, there's a change that allows physician presence. Well, it's going back to requiring physician presence, but the change is that this presence can, for certain situations such as consultation, medical emergencies, or patient referral, can be via a radio, phone, or electronic communication. For home health aides and hospice aides, there's a return to the required nurse visit that needs to happen every 2 weeks. For home health aides in particular, this requirement will go into effect December 31st, 2023. So with that, I'll pass it back to Amanda.
Great. Thank you so much, Jeana. A lot of information there. And we do have a question from one of our attendees. Jeana, you give a lot of information about different licensure requirements, and it sounds like every state could be different. Do you know of a good resource to look at cross-state regulations as it pertains to licensure?
That is a great question. I'm not aware of a single resource where they put all of the compacts and cross-state licensure rules in one place. But I will say I would definitely start by looking online at the resources provided by the licensure board that applies. So for example, if you have somebody that wants to come to Ohio, you can go to the Ohio Medical Board for physicians, you can go to the Board of Nursing in Ohio for nurses. But I think starting with the individual licensure boards is a good place to start. And then of course, if you have questions, we're always happy to help.
Awesome. Thank you so much, Jeana. So those are all the questions that we have on licensure and waivers. So next slide, please. We'll go ahead and turn it over to, I guess, to me to talk about COVID-19 testing, treatment, and vaccines after the PHE. Next slide. So we're going to start with Medicare, and I'm going to break this down into 3 categories. We're going to talk about Medicare, Medicaid and CHIP, and then private insurance. And then we're going to talk specifically about the vaccines and the boosters, testing for COVID-19, and treatment options for COVID-19 diagnoses. So starting with Medicare and starting with the vaccines and the boosters, as we all know, there is no cost for Medicare beneficiaries to receive either the vaccine or the booster. Right now, these vaccines are coming from the federal supply. So Medicare does not reimburse providers for the vaccine itself, but it does reimburse for the administration of the vaccine. Going forward with the ending of the PHE, we're going to see that beneficiaries still will have no cost sharing obligation. So just like any other vaccine that's provided to Medicare beneficiaries, it will be provided at no cost sharing obligation. But providers will need to start purchasing inventory and supply, and they will be reimbursed for the vaccine purchase and for its administration. So we're going to start seeing providers needing to purchase and administer this vaccine, just like any other vaccine that it may administer in the office or in the clinic. Now, when it comes to COVID-19 testing, currently Medicare will reimburse beneficiaries for up to 8 free over-the-counter at-home testing kits, in addition to the laboratory diagnostic tests. There is no cost sharing for either of these currently. And also there's no cost sharing obligation for COVID-related treatment. So if you do test positive, or if you had to undergo an office visit and then various tests like a strep test or a flu test to rule out COVID, all of those tests and treatments would be provided at no cost sharing obligations. And you may recall, if we take it back to 2020 at the start of the pandemic, the FFCRA, Family First Coronavirus Response Act, prohibited cost sharing for COVID related appointments, visits, and treatments. Also, there was a prohibition on requiring prior authorization or utilization controls over these types of services during the PHE. But now with the ending of the PHE, we're going to see some changes here. So for traditional Medicare beneficiaries, there's no longer going to be coverage for over-the-counter or at-home tests. They're going to need to purchase those out of pocket. Now, Medicare Advantage plans could provide these at no cost, or it could be an added benefit through that plan. But for traditional Medicare beneficiaries, there will be no coverage. Now, for diagnostic lab tests, so think of you go to the doctor or you go to a clinic and you have a COVID test, that's going to be covered by Medicare, and there is still not going to be any cost sharing obligation with that. However, there needs to be proof of medical necessity. So we need to follow the requirements like we would with any lab test. There needs to be an order by a licensed provider. There needs to be a supporting diagnosis code. And then, so there needs to be some proof of medical necessity. Recall that there was no coverage for lab tests, and that was during the PHE, and now no coverage for lab tests where there's a lack of medical necessity. So this would be proof of a negative COVID test to go on vacation, or if you needed it to go to work every week, if you were not vaccinated. There is no medical necessity indicated there. These would not be covered now or in the future. So If you are a provider and you think that this may be a risk area for you for a future audit, you may want to go back and take a look at those rules and make sure that you have your documentation in place. Now, finally, turning to treatments. So this would be COVID-related treatments following a positive COVID diagnosis. Again, under the FFCRA, these need to be provided during the PHE at no cost-sharing obligation by the beneficiary. We also see that oral medications like Paxlovid that are not FDA approved, but do have the emergency use authorization by the FDA, those are allowed during the PHE. And most of these treatments, because we have rolled out these drugs and antivirals, most of these treatments are coming from the federal supply. So providers are getting these drugs free of charge. So they're just getting paid to administer the drug, but not for the purchase or for the dispensing of the drug or the treatment. Going forward, we're going to see a more traditional approach. So these treatments are now going to be subject to the cost sharing obligation. We know for Medicare, it's a 20% cost sharing obligation for Part B. Also, Medicare Part D can go back to requiring that the treatment be FDA approved or that the drug be FDA approved, as opposed to just an EUA under the FDA. But note that Paxlovid is temporarily a covered drug under Part D. So there was a regulation that allows for Part D coverage of the Paxlovid, and we expect that we will have FDA approval at the end of 2024. Then we're gonna see providers needing to purchase their inventory, and then they will get paid for the administration, the dispensing, and the purchase of their inventory and for these treatments. Next slide, please. So let's talk about Medicaid and CHIP. Medicaid and CHIP are a little bit different. As Daphne noted, a lot of the funding has come from the federal government during the PHE, and some of that is not going to change. So starting with the vaccines and the boosters, because these are preventative services and these vaccines are recommended by the ACIP. Again, we have no cost sharing obligations for beneficiaries. Most of the supply or all the supply has come from the federal government, and the state expenses with administering the vaccines is 100% matched by the federal government at this time. Going forward, we enter the American Rescue Plan, which was passed at the end of 2021. The American Rescue Plan is going to require that states continue to provide the vaccines, testing, and treatments until September 30th of 2024. So another year and a quarter. And the states will continue to receive 100% of the matching payments, the FMAP that Daphne talked about in her presentation. And so again, we have vaccines and boosters are going to be provided free of cost, no cost sharing obligation, and the federal government will continue to match that through the end of September of next year. After that, the state standard will default back to their standard FMAP to offset those state expenses. So moving on to COVID-19 testing. The American Rescue Plan requires that Medicaid plans cover both over-the-counter testing and also diagnostic laboratory testing with no cost-sharing obligation. So again, we're going to see this after the ending of the PHE, continue on through September 30th of 2024. After that date, states it will be up to the state Medicaid plans to determine whether they're going to continue to pay for the over-the-counter tests. In some instances, we expect that we're going to require a valid physician order for that in order for it to be covered by the Medicaid plan. And then states also have discretion to impose any cost sharing obligations. But I would say with most Medicaid plans, there is limited or no cost sharing obligations on Medicaid services and payments. Finally, moving on to treatments. Again, the American Rescue Plan is going to require that states continue to provide coverage of COVID-related treatments without any cost-sharing obligation. through September 30th of 2024. And again, are going to get those federal matching dollars. Also, the federal government will continue to pay for oral treatments like Paxlovid at no cost sharing obligations. After the September 30th, 2024 date, states will have discretion as to what treatments are covered by Medicaid, and then also if they will impose any cost sharing obligations on beneficiaries. Next slide, please. So finally, moving over to private insurance. Currently, private insurance covers or is required to cover vaccines and boosters for COVID-19 without a cost sharing obligation. Again, most of this is coming from the federal supply. Providers are able to seek reimbursement from private insurers for the administration of the vaccine, but they're not able to bill patients directly. They're prohibited from doing that. Going forward, we're going to see these vaccines being treated like any other vaccine. Again, this is a vaccine that's recommended by the ACIP. So we do fully expect that these vaccines will be covered as a preventative service at no cost sharing obligation, especially under the Affordable Care Act. Of course, we have these grandfathered plans that can require cost sharing obligations or can choose not to cover it. But for the majority of plans, we expect that these vaccines will be covered without a cost sharing obligation. With testing, testing is currently covered without a cost sharing obligation, but again, you have to have proof of that medical necessity, and that harkens back to the FFCRA. Over-the-counter tests also have to be covered, but plans do not have to cover tests that are not medically necessary. They can also partially cover it and require a cost sharing obligation, but typically we see no coverage if there is no medical necessity. Going forward, though, it's going to be business as usual. We're going to see cost sharing resume. We're going to see in-network restrictions. So a lot of plans state that you have to go to a certain lab for it to be covered. And we're also going to see that over-the-counter tests are probably not going to be covered by these private plans. And finally, addressing treatments. Currently, the American Rescue Plan states that treatments with and without FDA clearance under that emergency use authorization should be covered, must be covered. There is the ability for private insurance to require cost sharing obligations if they choose, but this was as a part of the American Rescue Plan. Prior to that, they could not require cost sharing. That was under the FFCRA. But again, going forward, it's going to be business as usual. These treatments are going to be subject to in-network and out-of-network restrictions, cost sharing obligations, which includes your copays and deductibles. And we're going to see the return of prior authorizations, utilization review. So expect that, again, to be business as usual. Next slide, please. So just a summary, for Medicaid and CHIP, we're going to see these programs continue. And again, this is related to COVID-19 vaccines, testing, and COVID-related treatments. It's going to continue at cost-free, no cost-sharing obligation, supplemented by the federal government through September 30th of 2024. Also, now that the PHE is over, the Department of Health and Human Services is not going to require providers to report COVID test results, but you should note that they are asking providers to enter into these voluntary data use agreements to voluntarily report this data. So we're going to see that some of the data is going to be skewed because not all providers are going to be reporting. Again, it's going to be voluntary. But make sure that you check out your CMS participation agreement. As part of your CMS participation agreement, you may be required to report this data through April 30th of 2024. So I want you to be aware of that requirement. The federal government does have a federally purchased supply of vaccines and treatments and drugs. We don't have any extra funding for that. So the supply is now dwindling, and the federal government has committed to exhausting that supply. But once that supply is gone, it's going to be, again, business as usual. In healthcare, we're going to be looking to the commercial sector for those drugs and treatments to be purchased and then administered. And unfortunately, that is going to impact the uninsured and the underinsured who do not have coverage because this federal supply is not going to be available. And as Daphne talked about, a lot of the Medicaid coverage that we have now is going to be going away for some of the patient population. Now, early on in the pandemic, we did have coverage and payment for uninsured through HRSA. That program ended in April of 2022 because the funding ended, and again, it was exhausted. Some states have given temporary Medicaid coverage for testing and treatment to uninsured, but with the ending of the PHE, we're going to see that go away. And so largely our uninsured and underinsured population is going to be very much impacted by the ending of the PHE. But we will continue to have emergency use authorization under the FDA. And again, that's a lot of these treatments and drugs are expected to have FDA clearance in the near future. So with that, I will take any questions that you have. Okay, it looks like we don't have any questions, so I'll turn it over to Bryan to close us out with employment updates. You know what, Bryan? I think you're on mute.
Sorry. Yep, there we go.
All right, we can hear you now. All right, go ahead.
A lot of what we're going to recap here today may have already been discussed by Amanda or Jeana or Daphne, but we're going to put this spin on it from an employment law perspective. So let's start with this next slide, please. So we covered a lot of issues last week in my employment law presentation, but as a refresher, I want to focus on a few of the big ones. So throughout the pandemic, the government, through statutes such as the FFCRA, the CARES Act, and even HIPAA, such as what we've discussed here today, made various adjustments to these laws to respond to COVID-19. Many of those had an impact on employees, and many of these changes are actually scheduled to end with the public health emergency ending and reverting back to pre-pandemic status. So first, we discussed payment for COVID testing, and that's no longer going to be 100% covered as it was during the pandemic. As you'll recall, many of us were able to walk into a pharmacy or go through those dreaded drive-through lines to receive this testing, and we were able to send our employees for that testing when there was an infection suspicion, and we were never received a bill for that testing. In addition, we were able to seek reimbursement for over-the-counter testing kits that we purchased at the store. However, as of now tomorrow, insurance companies will now be able to implement rules that limit the coverage of testing, which we obviously suspect many will do, as we've covered here already today. So you're going to want to check with your plan administrator for your employees, but we expect many plans to implement medical necessity requirements for receiving this testing, as Amanda had mentioned, such as symptom checking to ensure that the experienced symptoms are actually aligning with what we expect of COVID infection. So what does this mean for you all as employers? Obviously, especially since many of you are all healthcare providers. Well, despite the PHE coming to an end, COVID as an illness is obviously sticking around. Therefore, you may still have employees who are sick with COVID and should be tested before coming to work or returning to work after an illness. And you're going to want to clarify with your health insurance plan and communicate that clarification to your employees to which extent testing is going to be 100% covered. So if the employee will now have cost sharing obligations, as Amanda had mentioned, which is obviously going to keep many from wanting to seek testing because of that out-of-pocket cost. So you should consider whether you will cover the cost of this testing for your employees if insurance isn't going to cover it, such as through the purchase of over-counter testing kits, or otherwise reimbursing employees for those kits, just to have on site or have available to your employees in the event that they present to work sick and you can easily test for them. We've developed some of these policies for our clients, and we can certainly help you evaluate these policies and think through these requirements and whether or not you want to put in some sort of continued testing policy for your employees once the pandemic PHE comes to an end tomorrow. So moving on to our second recapped point. Fortunately, preventative services, as Amanda had mentioned, such as vaccines, will likely remain covered benefits through existing pre-pandemic preventive service coverage requirements. These services will include things such as, the COVID vaccine, allowing for coverage as long as the recipient receives the vaccine from an in-network provider, right? So given that there will still be coverage for the vaccine, at least without cost-sharing obligations for network providers, many of your employees will continue to get the vaccine, at least, without regard to the monetary cost of receiving it. Let's move to the next slide, please. So during the PHE, your employees and ex-employees in some cases had extended periods of time to enroll in certain programs, such as to receive COBRA benefits and special healthcare enrollment windows. In many cases, employees were allowed a year for enrollment rather than the standard timelines, such as the 60 days for COBRA. However, given the end of the PHE, the notice and enrollment extensions that started during the PHE are no longer going to be valid. So you're going to want to revert back to pre-pandemic notice policies for plan enrollment, such as COBRA and employee health insurance programs. Your plan administrators will be able to assist you with your specific notice requirements to employees, in particular COBRA and healthcare enrollment. Along these same lines, during COVID, many people were granted extended health insurance coverage, typically through Medicaid, through at least March of this year. Medicaid generally has not canceled anyone's coverage. So essentially, some individuals, a lot of individuals, actually, including employees, current employees that you may have, actually continue to receive Medicaid coverage through March, despite being employed now or otherwise, not meeting those eligibility requirements. Essentially, the government says we're not going to end people's Medicaid during the PHE. So this is now obviously going to come to an end here. And so many people who are receiving CHIP and Medicaid benefits will no longer be eligible to continue on with those benefits. Therefore, many of these people will now need to transition to current employer-sponsored plans or go out on the marketplace if their employer does not provide coverage. So individuals who lose coverage due to ineligibility will be granted a special enrollment period to enroll in your employer-sponsored plan, for which they're otherwise qualified. So current employees must be given this chance, even if they previously turned down health insurance when offered because they still had Medicaid or CHIP coverage, and that now they're subsequently losing that eligibility. So if an employee or their dependents lose that eligibility for Medicaid, they must be given the special enrollment time through you as an employer. So in the coming months, the eligibility is going to change for tens of millions of people throughout the country, they suspect, and many of those are going to be reevaluated for de-enrollment in the program. And depending on your employee demographics, this could lead to a significant increase in the number of employees that are now going to be on your health insurance plan, even mid-cycle. So employers will need to begin, planning for and be mindful of, this potential increase of the participants in your employer plan. Finally, we discussed the breaking news announcement that came just last week that President Biden has officially ended the COVID vaccine mandates for federal contractor and healthcare employees. So the contractor mandate, which was never actually enforced very much, if at all, will end on May 11th, tomorrow, coinciding with the formal end of the PHE. However, the CMS mandate will take a bit more time to end, as it will require a formal rulemaking process. However, we do not expect much enforcement in the interim while they go through that rule process to revoke that requirement. Many of you still have these vaccine mandates in place as a result of the CMS requirements, especially if you're a healthcare employer. Therefore, you'll need to consider whether you will keep such policies in place moving forward. In addition, BMD has actually received some inside information, just this morning. Amanda has brought it to our attention that a group of at least 250 attorneys have been meeting to discuss ways that they can band together to sue government agencies, local governments, employers, such as healthcare providers and even school districts, continuing to argue that the vaccine and mask mandates were unconstitutional. Although we believe that many of these actions will be unsuccessful, we cannot prevent someone from filing a lawsuit. But we are preparing responses and strategies to defend against this frivolous litigation in the event that our clients, such as healthcare providers, government agencies, school districts, are the subject of such lawsuits. So we'll have more information on this topic in the very near future, so stay tuned for that. Next slide, please. So what should employers do now? Well, employers and plan sponsors should begin thinking about how the emergency period's expiration may affect their plans and what steps to take, such as considering amending plans, extending enrollment periods, and clarifying COVID treatment coverage for your employees to prevent any surprises and costs. Remember, these types of extensions are not only beneficial to your employees, but will also be much appreciated by your HR staff that will likely need to especially enroll many new employees in your plans. They're definitely going to appreciate that additional time to get that in place. So you should also use this time to review your COVID-related policies. Many of you implemented leave policies, testing requirements, and COVID vaccine mandates. Although some states still have COVID leave requirements in place, very few, in fact, though. The federal government's leave requirements no longer apply, and many other states with similar requirements expired long ago. Therefore, you're going to want to get these policies off of your books to ensure there could be no claims for breach of contract for not providing these benefits, to your employees, when, especially now that you no longer have to and no longer want to. So we'll want to review, or you will want to review, all of your applicable policies to consider to what extent you'll return your company to your pre-pandemic policies and procedures. And with that, I think we'll move on to see if there's any questions and further discussion.
Awesome. Thank you so much, Brian. Again, if you have any questions, please type it into the questions box. Our contact information is here on the slide. And as Ashley stated at the beginning, to review our previous 5 presentations, please visit our website, click on our resources tab, and you'll find articles and then also the replay of the other 5 presentations that go more in depth with these changes. For all of you that attended, a copy of the slides will be distributed to you after the webinar, and the replay will also be made available to you. As Brian stated, we had some hot off the press news occur this morning, and so please stay tuned for more information from us on that topic. Thank you all for attending the webinar today, and we look forward to speaking with you again.